researcher colleagues whom you represent, and I really appreciate that. My questions, I've got a bunch of them. First, I just want to make the point that there's been a lot of effort here, a lot of discussion about the NIH to do more, to hopefully develop these therapeutics as rapidly as possible. I will point out something which is counterproductive, and which has been shown to be counterproductive, which is the most frustrating thing, which is the administration is pushing that if there are cures with NIH money, that the federal government can march in and dictate whether or not the intellectual property is taken if they don't like the price. That has been shown in the past to inhibit investment by the private sector. And it's very populist. It probably does well on a campaign trail. It's going to be bad for this. And I'm just going to make that point because we've made it before, but maybe this is the time that will actually mean something to people, to actually promote development as opposed to promote a populist appeal. Next, Dr. Harkin. A lot of conversation. Dr. Walker mentioned Project ECHO 2. You're from the hometown of Project ECHO. How effective has ECHO been in terms of transmitting this? What is the uptake among primary care providers logging on to hear from you or Dr. Walker or whomever as to how to better manage these patients?
Thank you for the question. We have over 100 participants in this particular post-COVID primary care ECHO program that we're running.
Now, participants are sites or participants are individual physicians?
Individual participants, and the majority are practitioners.
So 100 different doctors?
800.
800, I'm sorry, I missed
Yes, 800. And so what we're seeking are case presentations from these patients, from the providers, but they were uncomfortable or not knowing how to diagnose long COVID. Is it long COVID? So we have done case-based presentations. I
get that, but I have limited time.
Okay, so we have efficacy data where they feel more comfortable. We are doing polls. They can actually answer the questions. Now, yes, this meets a long COVID diagnosis. Yes, this would be the next step to do.
And as Dr. Walker, you had said you need to decentralize the management of this. Are you finding these road shows and these ECHO programs decentralizing the management yet?
These are just being launched now as AHRQ is just funded. I don't expect that it will be decentralized soon. This is a 5-year endeavor, and I expect that we'll need to have that full 5 years, if not longer. It's a very complex disease, but during these 5 years, there'll be a very intensive capacity building effort amongst primary care physicians within our regions. Sounds
great. Dr. Ali, let me just ask you, because it begs to be answered. We do know some of the I've been sitting up here reading my PubMed. So we do know that there's different pathological mechanisms by which it is theorized COVID would do this. In some cases, it's immunologic dysregulation. Other places, it's gut dysbiosis. In other cases, it's thrombi. But there are specific treatments for each of those. For example, one of our witnesses said that her daughter had been given a colonoscopy, put on probiotics, which could be irritable bowel syndrome superimposed, but nonetheless it worked. So I guess I'm a little bit, and I know there's an answer for this. I presume the approach is, wait a second, here we have studies showing that thrombi are probably involved. And here, to the degree we can separate those two, it seems to be immunologic dysregulation. And here's something else. And it seemed like there could be a therapeutic intervention, even if not in a clinical trial, aimed on each of those. Is that being done? And if so, what are the successes of this kind of personalized approach?
This is what gives me hope, is that our understanding of the mechanisms of long COVID has actually improved over time. And we know that there's, gut dysbiosis. We know that there are micro.
Let me stop you, though, because, again, I got limited time, and he's now the chairman. But we've had some of this information for a couple of years now. And that's time enough for people like, for example, the GI doc who ended up giving the patient the probiotics and making a positive improvement. So to what degree has this information that we've had for 2 years been translated by clinicians into different approaches, even if it's empiric?
Very, very poorly. I think the broader sort of provider community don't really have a very...
Okay, then go back to the long COVID treatment centers, because we funded 8 or 9 of those. And so how are those doing implementing this information?
So those are currently treating people symptomatically, and some of them may be trying, maybe trying different treatments according to different mechanisms. But I think really the core issue here is that the only solid way we know treatments works is by doing RCTs or randomized controlled trials.
Oh, I get that totally. On the other hand, I think it was maybe you, Dr. Matlack-Brown, who said we could have the real world experience. Sometimes a RCT is stimulated by, hey, look at this. In this subset of patients, this really seemed to work. Now let's check it. It isn't random by which you come up with a random control
And I think a lot of that anecdotal evidence and also the basic and mechanistic evidence is informing the development of clinical trials. I think the point, though, is that the number of trials that are now currently planned or ongoing is too small and too slow and to really yield definitive answers
Got that.
in
Okay,
the
Dr.
time that
Hart,
we need them to.
Dr. Harkin, back to you. I've read, sitting here reading, and apparently physiotherapy in some cases helps people with pulmonary disease because it strengthens the diaphragmatic muscle and they can breathe better. But we heard, you know, in some cases, exercise actually exacerbates the underlying symptomatology. How do you, as a pulmonologist, figure that out? Or is that empiric too?
Well, you have to have a conversation with your patient, and you have to really understand what their limitations are. There are several studies that show that pulmonary rehab do actually help patients, certain select patients with long COVID, with better outcomes. I think it has to be individualized and multidisciplinary. You have people that help you breathe better. You have people that can help you do a little bit of activity, whether it's resistive or et cetera, depending on what you can do at baseline. You can't just have a one prescription fits all patients with long
So how
COVID.
do you differentiate that is my question. Now, how do you come up with a person for whom gentle exercise will gradually strengthen and gentle exercise will otherwise further exhaust?
Well, that is the difficult part, but it's really in trying to get a history from my patient. What can they physically do day to day? Are they getting better? Is this improving over time? Maybe they are a person that could do this pulmonary rehab, but someone that can't get out of bed because of severe post-exertional malaise because of something they did the day before, that's someone I'm not going to send to general pulmonary rehab.
I'm way out of time. Let me just say one more thing. Ms. Beal, when she spoke of wishing to speak directly to her provider and having that kind of therapeutic relationship of being able to look someone in the eyes, not through a Zoom screen, but, and I've been there too. And I just thank you all for being those who provide that face-to-face. With that, I yield.